Thank you so much, everybody, for joining us this evening. It's wonderful to be here, and thank you to the Society for Vascular Surgery for hosting this webinar. It's been a true honor of mine to get to work with an international group of surgeons and anesthesiologists, APPs, and therapists on the perioperative guidelines for open aortic surgery. This is a combined endeavor between the SVS and the ERAS Society, and is really a dream of mine that I'm so glad to see come true. And I'm so glad to see so many of you participating in the webinar to learn more about it. Initially, I thought ERAS was something that general surgeons did to reduce the amount of ileus after abdominal surgery and hopefully get their patients out of the hospital sooner. But as I learned more and more about it, I saw that it was actually so much more than that. And our patients, vascular patients, are the most vulnerable patients in the hospital and really have the most to gain. And so hopefully over the course of the evening and the lovely pre-recorded talks that we have, you will see that ERAS has a lot to offer you and your patients. And we look forward to entertaining your questions at the end. So our first speaker is Dr. Emily Spangler. She's an associate professor of vascular surgery and endovascular therapy at the University of Alabama at Birmingham. Her areas of interest include lower extremity occlusive disease, complex endovascular repair, also open and catheter-based treatments for aortic aneurysm, carotid disease, and she is an outcomes researcher. Dr. Spangler is presenting ERAS overview. Why do we need ERAS in vascular surgery? Welcome, Dr. Spangler. The screen is yours.
Good evening. I'll be speaking on why we need ERAS in vascular surgery, the challenges we have, the opportunities this presents, the approach ERAS brings, and the benefits of ERAS in aortic care. So to begin with, vascular surgery patients are among the most medically complex patients across surgical specialties. By measures of the Lichthauser Comorbidity Index in work from Dr. Barrell's group, vascular patients are second only to cardiac patients in comorbidity index, with overall trends towards increasing surgical comorbidities in patients over time. Combined with that, many of the open cases we perform have significant physiologic impact to patients, especially in cases such as aortic care, where the hemodynamic changes and ischemia reperfusion concerns of aortic cross-clamping are added to the stress of surgery on a patient. Additionally, the landscape of healthcare is complex for our patients, and our surgical outcomes reflect more than just our intraoperative care. Indeed, healthcare delivery spans involvement of many individuals, with 50 or more people from many specialties and roles anticipated to interact with a patient over the course of just a 4-day hospital stay. The breadth of interactions, however, can risk variation and gaps in care. From these cumulative challenges, we have an opportunity with ERAS programs to standardize care and improve quality of care delivered. The ERAS approach is rooted in concepts of multimodal surgical care postulated by Dr. Kellett in 1997. In his paper, he outlined a path of modifying the elements shown towards limiting physiological impact of surgery and reducing postoperative morbidity in colon surgery. Subsequently, a dedicated study group performed trials from 2001 to 2004 in Europe, and an evidence-based consensus protocol began to be disseminated in 2005. ERAS further expanded to other procedures in colorectal surgery and then beyond. The aortic ERAS guidelines that we will be reviewing here were published in 2022, with lower extremity bypass and amputation guidelines published in the subsequent years. At this point, you may be considering why vascular was late among the surgical specialties to participate in ERAS. However, we had the dissemination and uptake of endovascular therapies that was its own path to reducing surgical stress in the interim. However, in caring for patients who may not be appropriate for things like EVAR, it's important now to reassess how we can improve care and outcomes for our open aortic surgical patients. The ERAS website also has a breadth of information, including archives of all the society guidelines and resources for anesthesia, nursing, and allied healthcare providers. The ERAS principles span over the arc of care from preoperative through postoperative. The majority of the preoperative focus is on risk factor stratification, patient optimization, patient education and expectation setting, and then further into the intraoperative course, specifically attenuating surgical stress, and in the postoperative period, returning to and maintaining postoperative physiological functions. A note about wording that may be encountered as you look at this literature or are new to this topic. For ERAS, that implies a society endorsement of the statement or protocol. ERPs, or Enhanced Recovery Protocols, are commonly used terms, but not necessarily ERAS endorsed. These may also have the benefit of giving specifics about an individual institution's implementation of their program with enhanced recovery focus. Fast track is a term that is more broad and variable in its meaning. It was used in much of the earlier literature. However, there were sometimes issues that the care was not with a multimodal or transdisciplinary approach, or lacked patient engagement. Sometimes this implied only using a retroperitoneal approach of a limited incision, and sometimes the focus was on defined dates of discharge, such as leaving the hospital from aortic care at postoperative day 3, a goal that realistically few, only about 20%, reached. Overall, I want to focus on the enhanced recovery aspect. This is a shift in emphasis from speed of recovery to quality of patient care over the course of their diagnosis through recovery, and that the speed comes as a byproduct from this. So if you think of having to get from one place to another, if you're going through a course of series of twists and turns and challenges of a hill, these can all make your path slower than if you have a wide open road without obstacles ahead of you. Similarly, the enhanced recovery focus, by modifying a number of different elements along the way, can help straighten out the path of recovery for our patients to make it speedier. In particular, given some of the publications about fast-track care, there is a good quote from an editorial by Vandervliet and Van Goor that noted, "Enhanced recovery and long-term recovery after surgery should be the primary goal of clinical pathways and not decreased hospital stay." So how do we achieve this? The SVS aortic ERAS guidelines will be reviewed in more detail in the subsequent parts of this seminar. Broadly, in the preoperative phase, we're focusing on optimization, intraoperatively on stress minimization, and postoperatively on protocolized normalization across a number of different elements. Counseling and audit of compliance and outcomes remain important throughout the course of these phases. In the pre-admission aspect, our recommendations focus on risk factor screening, risk factor optimization, and incorporating the concept of prehabilitation in patients with elective cases. In the preoperative phase, more immediately perioperative, is where a lot of the newer concepts reside for vascular care. Much of this has been abstracted from other ERAS protocols of major abdominal surgery, and future vascular-specific evidence-based will need to be refined. In particular, the items that may be new to providers include limiting fasting duration, carbohydrate loading, and multimodal pain control strategies. Additionally, medication therapy recommendations around multimodal pain control and nausea vomiting prophylaxis, as well as DVT and antibiotic prophylaxis, are reviewed. In the intraoperative phase, a focus on the anesthetic strategies is also given, and use of epidural anesthesia, maintaining nomothermia, and avoiding drains where feasible. In the postoperative phase, a focus again on multimodal analgesia and opioid reduction strategies, as well as removing lines and tubes and return to normal intake and output. Finally, early mobilization is important, as is education continuing through the discharge phase and an audit of outcomes and implementation. While it may seem overwhelming to have 22 different elements of focus within guidelines, not all recommendations have aortic-specific evidence base available, and some have varying ease with which they may be implemented. However, uptake does not need to be all or nothing. In other ERAS protocols, however, increasing compliance around the elements used was associated with decreased complications and decreased length of stay. The benefits that we've seen are as follows. In one infrarenal aortic fast-track randomized controlled trial, which used a majority of elements within the current ERAS recommendations, they found in their post-hoc analysis a lower incidence of SIRS response by nearly half among their patients, and a lower incidence of organ system dysfunction. This was postulated due to be a reduction in surgical trauma and clamp-related ischemia-reperfusion injury with ERAS. So these results would suggest ERAS interventions are likely modulating the surgical stress response. For more broad clinical outcomes, in the literature we now have a meta-analysis of results of prior studies which range from descriptive to randomized controlled trials of fast-track and ERAS therapies. Elements tracked in the included protocols included things like screening, medical optimization, patient education, fasting and carb loading measures, early antiemetics and early analgesia in the preoperative phase, patient warming, goal-oriented fluid-directed therapy, and short-acting anesthetics in the intraoperative phase, and in the postoperative phase, opioid reduction, early mobilization, multimodal analgesia and epidural use, fluid management strategies, and line, catheter, and drain management, as well as regimens for bowel and diet and discharge coordination. These studies variably included each of these elements within their protocols. Overall, there was a mean reduction in length of stay by 3.18 days, and no study had a longer length of stay in the ERAS cohort compared to usual care. In meta-analysis of major complications, a lower odds of major complications were seen in ERAS with an odds ratio of 0.38. Individually, one of these authors also published a series of their work on over 1,000 patients receiving ERAS care. In that cohort, Brustia and his group found that acute kidney injury was the most common complication for his cohort, with about a 2% incidence, and cardiac complications occurred in about 1.5% of cases, most of which were temporary arrhythmias. Early rehospitalization was also approximately 2% within their cohort. In meta-analysis of 30-day mortality, no significant 30-day mortality difference was observed between groups. With ERAS care focusing on delivering optimal care over multiple domains, we don't necessarily need perfect implementation for patients to have benefit, but a protocol in isolation without multidisciplinary engagement or auditing for quality improvement has not been shown to change practice within other ERAS protocols. So other members of our team will also be sharing with you lessons learned from their implementation. In conclusion, enhanced recovery principles and structured protocols in open aortic care are designed to achieve early recovery for patients undergoing major surgery. They are safe and feasible, can engage patients and multidisciplinary teams, reduce variation in care, modulate surgical stress and recovery, and are associated with reduced length of stay and lower odds of major complication. I hope you look forward to implementing aortic ERAS for your patients.
Our next presenter is Dr. Simon Howell. Dr. Howell is an associate professor of anesthesiology at the University of Leeds. His areas of expertise include cardiovascular complications of anesthesia and surgery, risk estimation in surgery, frailty in the surgical patient, exercise and functional capacity in surgical patients. And this evening, Dr. Howell will be presenting the necessary collaboration of surgery and anesthesia in the implementation of successful ERAS pathways. Welcome, Dr. Howell. The screen is yours.
Good afternoon, ladies and gentlemen. My name is Simon Howell. I'm an Associate Professor of Anesthesiology at the University of Leeds in the UK. And it is my pleasure to talk to you about the collaboration between surgery and anesthesia in the implementation of enhanced recovery pathways. These are my declarations. None of them are directly relevant to the talk that I am about to give you. I'd like to talk a bit about the importance of shared understanding and goals in the delivery of enhanced recovery after surgery, a bit about preoperative assessment and optimization, something about the use of epidurals and about postoperative analgesia, and something about the importance of stable teams in delivering enhanced recovery. Shared understanding and goals. Enhanced recovery after surgery is a complex intervention. The underlying principles may be relatively straightforward, but this is a multi-component program that requires clear understanding from surgeons, anesthesiologists, radiologists, vascular nurses, and others as to exactly what is to be delivered and a coordinated approach to delivering it. No single individual can successfully deliver an ERAS program on their own. We need to have a shared understanding and to work together in order to do so. Assessment and optimization. I'm an UK anaesthetist and I'm going to give you a UK perspective, but I believe that the points that I make are universally applicable. Preoperative risk assessment, preoperative medical assessment are an integral part of the delivery and enhanced recovery and are enshrined in the care of aortic surgery patients. The Aortic Surgery Quality Improvement Framework in the UK from 2011 stated explicitly that all elective aortic surgery patients should be seen and risk assessed in a pre-assessment clinic that should involve a consultant vascular anaesthetist, and that the output from this risk assessment should be available for the multidisciplinary team discussion of the patient in the aortic MDT. It further stated that that MDT, that multidisciplinary team, should involve a surgeon, a radiologist, and an anesthesiologist as a minimum. But on the heels of this statement came the 2012 document on the provision of services for patients with vascular disease in the UK, again explicitly stating that anaesthetists, as we would say in the UK, should be present at the MDT. We have made progress with this. This is some work that I've been involved with recently, looking at the management of abdominal aortic aneurysm in the UK. About half of aortic MDTs have an anaesthetist regularly in attendance, although that drops to just over a third when the complex aortic MDT is considered. So we've certainly made progress, although there is some way to go. So what does this preoperative assessment give us? Preoperative assessment and optimization is amongst the key killers of enhanced recovery, and there are now clear processes for this and clear evidence of benefit. There seems little doubt that a systematic program of pre, intraoperative and postoperative care can reduce the burden of delirium in the older patient, improve short-term outcome, and potentially improve long-term outcome. Many older patients are on many medications, recipients of complex polypharmacy. Again, this can often be rationalized and optimized preoperatively, and plans can be made for appropriate restarting of medications post-operatively, and there is evidence that this improves outcome. Preoperative anemia management, again, is a mainstay of ERAS, including a careful assessment of why the patient is anemic in the first place, then appropriate treatment with iron, B12, folate, occasionally erythropoietin and related drugs as appropriate. These interventions are undoubtedly effective, but take time to deliver. Not only do the diagnoses have to be made in the case of anemia, but whichever of these approaches we're talking about, there is time is required for implementation and impact. And there is a tension between the medical optimization of the patient prior to aortic surgery and the pressure to proceed with aortic aneurysm repair, particularly in the case of a large aneurysm. That's a decision that has to be tailored to the individual patient and requires close collaboration between anesthesiologist, surgeon, physicians, and other members of the team. There isn't a one-size-fits-all solution. As patients progress down the aortic surgery pathway, they meet surgeons, radiologists, anaesthetists, vascular nurse specialists. This work, again, now over a decade old, but I believe still very resonant, makes the point or brings out that we must be clear and consistent in how we speak to patients. The word cloud from the focus groups conducted with patients both before and after surgery makes it clear that they certainly expect to spend time with speaking to the surgeon, but also wish to hear from the anaesthetist, from vascular nurses, that they want to know what to expect both pre and post-operatively, that they worry about pain, they worry about follow-up and who they should contact. It is important that all members of the team are consistent in what they say to patients, in explaining the decisions are made at the MDT, in the estimates of perioperative risk and the expectations of the post-operative course that they describe to patients. It is important that we say much the same thing to our patients, that we're consistent in our messaging and don't confuse them. That requires close team working and an understanding across the team of how the patient pathway is managed. Analgesia and epidurals. In the ERAS guideline for aortic surgery, we have come down clearly in favour of the use of epidurals, and there is evidence from a number of large studies that a combination of general and epidural anaesthesia potentially yields better outcomes than general anaesthesia alone. But I would absolutely accept that the signal is not unambiguous, and that there are also studies that are not consistent with this claim. However, I think what is enshrined in ERAS and is true for aortic and other types of complex surgery is that a multimodal analgesia strategy has the reducing the doses of opiates to given to patients has the potential to significantly improve outcome. In this study, the authors looked at postoperative delirium, comparing patients who received epidural anesthesia and those who did not, and looking at the oral morphine equivalents, the opiates they were given in oral morphine equivalents in the 7 days after surgery. Those who developed delirium were less likely to receive epidurals and more likely to receive high doses of opiates in the first 3 days after surgery. An opiate-sparing strategy, be it using an epidural or using other regional techniques, has the potential to improve outcomes for patients, but again requires a joined-up multimodal analgesia strategy across the patient, across the operative course, and close working between the anaesthetic and surgical team. The effects of epidurals on the cardiovascular system are well known, with sympatholysis from thoracic epidural blockade, potentially reducing sympathetic cardiac load to the heart and causing both venodilatation and arterial dilatation, resulting in the risk of perioperative hypotension. Therefore, most anesthesiologists do not put local anaesthetic into the epidural until the aortic cross clamps are off and hemostasis is secured. We may put opiate into the epidural at the outset, but a lot of people do not establish the full local anaesthetic block until towards the end of the operation. That requires effective communication between an anesthesiologist and surgeon. The anesthesiologist needs to be certain that the surgical team are content, not only that the aorta is unclamped, but that hemostasis is secure before initiating epidural blockade. Finally, and perhaps most importantly, is the team delivering this care. These data from a single centre compare the outcomes of patients undergoing elective vascular surgery who are managed by anesthesiologists without a regular vascular practice and those who did have a regular vascular practice. And as you will see, the lines diverge over time. There is a significant difference. The best outcomes are delivered by teams that work together, are familiar with each other's practices, hold regular governance meetings together, and communicate well. Of all the components to deliver this complex package of ERAS, a stable, effective team is probably most important. So in summary, my take-home message is, delivering the complex intervention that is ERAS requires shared goals and collaboration. Preoperatively, assessment should feed into the MDT and inform decision-making. Consistent messaging to the patient is required, and the components of ERAS, preoperative optimization, need to be balanced against the urgency of surgery. Intraoperatively, effective communication between colleagues within the team, including the surgeon and anesthesiologist, are essential. Postoperatively, an effective program of multimodal analgesia has the potential to significantly improve outcome. Most important is a stable team working together under an effective governance structure. Thank you very much for your time and attention.
Thank you very much, Dr. Howell. It was a wonderful talk. And next up, we have another anesthetist from the UK, Dr. Katie Ayash. She will be presenting ERAS and open aortic surgery, the current guidelines and review of the literature. Dr. Ayash is a consultant anesthetist in perioperative medicine. She's the clinical lead and honorary lecturer at the Hull and York Medical School and the York and Scarborough Teaching Hospitals, which is part of the NHS Foundation Trust. Her clinical work is mainly in vascular anesthesia, major colorectal surgery, and regional anesthesia. Her special interests are in the perioperative care of high-risk surgical patients, and she's become more interested in prehabilitation and the use of cardiopulmonary exercise testing for risk stratification. Dr. Ayash, thank you so much for joining us. The screen is yours.
Thank you for the kind introduction and for the invitation to speak. I'm going to spend the next 12 minutes or so going through the role of ERAS in the perioperative care of open aortic surgery. So I sit on the VAS-GBI subcommittee for audit and research, but I have no financial disclosures. In 2022, evidence-based ERAS guidelines were published by the Society of Vascular Surgery for open aortic surgery. And the Society for Vascular Surgery and ERAS Society selected an international committee of vascular surgeons, anaesthetists, and advanced providers who had expertise in enhanced recovery, but also in vascular pathophysiology. And we used a graded approach to rate the quality of the evidence and to grade the strength of the recommendations. And we came up with a total of 36 recommendations, which were categorized into pre-admission, preoperative, intraoperative, and postoperative. But because of time constraints, I won't be able to talk through all 36 recommendations. So what I've done is I picked out the ones from each category which I felt were most relevant to anesthesia. So this is Henrik Kellett, as we all know, is the godfather of ERAS. So over 20 years ago, he figured out that something wasn't quite right in patients undergoing major surgery. And we know major surgery is associated with undesirable sequelae. So he set about implementing an enhanced recovery after surgery framework that he felt would reduce perioperative complications. And he strongly believed that this framework would help to reduce length of hospital stay and complications, but would also improve the quality of care that patients received, and patients really liked it. And ERAS has never been shown not to work regardless of patient or surgery type. So ERAS has been the standard of practice in the UK for over 10 years now. And it's been shown to increase productivity and quality of care as well as patient satisfaction, but it also reduces costs by reducing length of hospital stay and complications. So we've been practicing ERAS in other surgery groups, and there is no reason as to why an ERAS program cannot be translated in the vascular sphere. There were no national guidance, and hence the reasons for developing these guidelines. So the guideline has nicely set out recommendations for each phase of the perioperative journey, and I'm going to talk through each one of those in turn. So let's look at the preoperative challenges facing vascular patients. We know that patients presenting for vascular surgery tend to be older, sicker with multiple comorbidities, and with poor physiological reserve. They tend to be on multiple medications, are frailer, and are poorly nourished. So the quality of the evidence was graded using the grade approach, and these were graded as either weak or strong, and the recommendations were made on the quality of the evidence ranging from very low to high. There's 10 preoperative elements, but what I've done is I picked out the ones which I felt were most important. We all know that anemia is bad for you, especially before major surgery. So it increases your risk of cardiac events post-surgery, you tend to stay in hospital for longer, and your recovery may be slower. It also increases your risk of having a blood transfusion, and this doesn't come without its own risks such as transfusion reactions, ABO incompatibility, and so on. Blood is also immunogenic and has been implicated in cancer recurrence. So giving a blood transfusion in the preoperative setting should be an absolute last resort. The evidence base for anemia is weak, and this has been shown by the PREVENT trial. So this was a double-blinded randomized controlled trial, and patients were randomly allocated to receive either IV iron or placebo 10 to 42 days before surgery. And what the study showed is that even though IV iron is a safe and effective treatment for perioperative anemia, there was no benefit in giving it because it didn't reduce the frequency of blood transfusions or mortality relative to the placebo group. But what it did show was that there was a reduction in readmission rates in those who did receive IV iron. So this is an example of a pragmatic approach for the management of preoperative anemia in the elective setting, and this was described by the Centre for Perioperative Care. I can't go into details of it because of time constraints, but the take-home message here is that iron deficiency is best treated with oral iron 3 to 4 weeks before surgery. In an emergency setting, we really need to be pragmatic. So if someone presents who needs an urgent aneurysm repair with a hemoglobin of 70, then yes, you would consider giving them a blood transfusion. You don't have to be thin and frail to be malnourished. You can also be obese and be malnourished. And what makes this patient group more susceptible to malnutrition is that they are often older, have lots of chronic health problems, and have absorption problems relating to their medications. They are also inactive because of claudication pains that they get from their peripheral vascular disease. We know that being malnourished increases your risk of wound infections and length of hospital stay, and is also associated with an increased mortality. So it's really important to recognize it and to treat it early. There are lots of tools out there for identifying malnutrition, and the one that we use in York is the Malnutrition Universal Screening Tool. So if you identify someone who is at risk of malnutrition or is malnourished, then the recommendation is to treat this more than 7 days before surgery by offering the patient oral nutritional supplements. And this is the preferred method to enteral or parenteral nutritional regimes because of the risks associated with them. And whether this improves outcomes is not really known. Frailty, as we know, is a multifactorial syndrome and is associated with a loss of physiological reserve across multiple organ systems in the absence of any underlying pathology. We know that frailty increases your risk of developing complications post-operatively. It also increases your length of hospital stay, and for some patients, they lose their independence and they can't go back to their own homes. While sarcopenia is an age-related loss of skeletal function and muscle mass, it is the single most important cause of frailty in older patients. There is some overlap between the two conditions, especially in terms of the physical aspects of the frailty phenotype. There are various tools which you can use to identify frail patients, and the one that we use in York is the Clinical Frailty Scale. You can also use a CT scan to identify frailty. But if you identify someone as being frail, then the recommendation is that they should undergo a comprehensive geriatric assessment, and this is considered to be the gold standard. In the absence of this, we can look at modifiable risk factors in the pre-assessment clinic. So for example, we can look at medications that may precipitate an AKI or hypotension, and look at factors for developing delirium and to try and address these. There are lots of elements in the preoperative section with strong recommendations as shown in this slide. However, the recommendation for prehabilitation is low as the general evidence for it is lacking. And even though there is good evidence for carbohydrate loading to show benefit in other surgical groups, there are no randomized controlled trials looking specifically at the role of carbohydrate loading in vascular surgery patients, and so we can only recommend its use in non-diabetic patients. We came up with some intraoperative recommendations, and I'm going to focus on the anesthetic protocols, cardiovascular monitoring, and renal protection. So it's simple. The anesthetic for having an aneurysm repair is no different to any other major abdominal surgery. We should all be using short-acting agents because they reduce the risk of confusion and delirium, and it really doesn't matter whether you use volatile or TIVA. There is some suggestion that TIVA does reduce the risk of delirium. We recommend using lung protective ventilation, so that is low tidal volumes of 6 to 8 mL per kilo, PEEP of 5 to 7 centimeters of water, and regular lung recruitment maneuvers. It's really important to make sure that your patients are adequately reversed at the end of surgery. Cardiac output monitoring may be useful, but what we have to bear in mind are the swings in hemodynamics that we see as a result of cross-clamping and unclamping. Looking at trends is what's important, and not at individual numbers in a single point in time, and this is really going to help you to guide intraoperative fluid therapy. The recommendations in terms of blood pressure is to maintain a MAP at your baseline, or a minimum of 65. Baselines are really difficult to know and ideally require 24-hour blood pressure monitoring. So this value of 65 has been derived from several studies. The first suggestion of what is classed as too low a MAP came from work by Walsh. And we can see from the graphs that a mean arterial pressure of less than 55 was associated with both acute kidney and myocardial injury. And this risk increased with the amount spent below this threshold. So if we look at acute kidney injury, after 40 minutes, the risk is doubled, and after 80 minutes, the risk is tripled. Even if you spend a couple of minutes below a MAP of 55, it increases your risk of developing both renal and cardiac injury. So the longer the time spent in hypotension, the higher the risk of AKI and myocardial injury. And this was echoed by work by Salmassi. And what they did is they plotted the MAP against the risk of outcomes. So when the MAP was less than 65, or there was a decrease of blood pressure of 20% from baseline, the risk of AKI and myocardial injury increased below these thresholds. They then took these thresholds and divided people into quartiles of time spent below it. So the longer the time you spent below these thresholds, the greater your risk of developing an AKI or myocardial injury. They then looked at the cumulative time spent below a MAP of 65. So the longer the time spent under this threshold, then the chance of injury was much higher. A MAP of 65 is the absolute minimum and is really the target that we should be aiming for. However, a recent study showed that harm does occur below a higher threshold of a MAP of less than 75 across a range of organ systems, and this can actually be more harmful. This really applies to our vascular patients who are more than often hypertensive. So all the evidence that we've seen so far is from retrospective observational studies where associations are made rather than causality. But be aware not to drive the blood pressure or to treat it at the expense of volume. So there was a trend in the US to decrease intraoperative fluid administration and to increase vasopressor use to treat hypotension. And what they found was the incidence of AKI was much higher, around 14% compared to other studies of 5 to 7%, and this may be because of the older study population. So the take-home message here is that don't squeeze a dry system and don't squeeze them to death, else you're going to see an increase in AKIs. So acute kidney injury is prevalent and is mainly due to hypotension. The majority of these are AKI1s. So even if transient, this injury is not benign. So it increases cost and length of hospital stay, and in some people it leads to chronic kidney disease. So what can we do to protect the kidneys? This is really for infrarenal repairs. So using ischemic preconditioning to reduce kidney injury is harmful and is not recommended by NICE, but we don't know if there's any benefit for suprarenal repairs. There may be a role for the use of mannitol, so there was one small study which showed benefits for suprarenal, but this hasn't been replicated. Other intraoperative recommendations, so we strongly recommend using epidural analgesia and maintaining normothermia. There are lots of strong recommendations postoperatively, and we can see in other ERAS surgery types, and it's really the same for aortic surgery. So it's really important to make sure patients have appropriate multimodal analgesia. We feed them early and avoid drowning them in IV fluids, remove drains and catheters as soon as possible, and we aim to get them out of bed as soon as we can and get them home. So to summarize, enhanced recovery has been shown to be beneficial to other surgical specialties. It's really easy to implement an ERAS protocol, and after we implement these guidelines, it's really important to audit our practice. It's going to help reduce variations in the postoperative care that patients receive. So if we're already doing ERAS for other surgery types, I see no reason as to why we can't start implementing this practice for aortic surgery patients. And thank you for listening.
Thank you very much, Dr. Ayash, for an enlightening presentation. Our next talk this evening is from Dr. Alberto Settembrini. He is a vascular surgeon and adjunct professor of vascular surgery and practices in the Fondazione Policlinico in Milan and is a professor at University of Milan. He also has had experience in the Novara Hospital with Dr. Piero Brustia, who is truly the pioneer of ERAS and aortic surgery. That experience allowed Dr. Settembrini to know and understand and really deepen the ERAS approach to aortic pathology. And these groups in Northern Italy are truly the people with the most hands-on experience for ERAS and open aortic surgery. And so I'm delighted to invite Dr. Settembrini to present to us a case example of ERAS aortic guidelines in practice. The screen is yours.
Good morning to everybody. First of all, I would like to thank the Society for Vascular Surgery for this opportunity to be here, and Dr. McGinnigal and Dr. De Boer to have led our fantastic group of the steering committee for the guidelines of the ERAS in vascular surgery, specifically aortic, peripheral, and amputation. Today I have the pleasure to present a case example according to aortic guidelines in practice. I would like to start with this interesting commentary that involves all the concepts of ERAS. In fact, in ERAS there is no I, but it is a really multidisciplinary approach to vascular patients. ERAS has been a philosophy before evolving toward a multidisciplinary program. This multidisciplinary program would like to take care of the patients to control the perioperative physiology, to maintain the hemostasis during the intervention, and to reduce the stress and accelerate the convalescence in the postoperative. Multiple studies have already demonstrated good results in ERAS in general surgery and other specialties, but some papers has already been published in aortic surgery, but in vascular surgery ERAS programs are not so well developed worldwide. ERAS pathways have been beneficial for many surgical specialties, as I said, and in vascular surgery it is important to develop some programs like this because our patients are affected by advanced age, frailty, and multiple comorbidities, and they are going to invasive operation. The combination of the different factors results so in a complex management strategies, increased utilization of healthcare resources, prolonged hospitalizations, and use a lot of hospital things. Our group started in Novara in the late years of 90s with Piero Brustia, who was a really pioneer in ERAS in vascular surgery, and he published his first paper of his first experience in over 1,000 patients with ERAS protocol in 2015. And later we published also the approach with the patient with suprarenal cross-clamping. Our patient today is a male, 72 years old, affected by COPD, CAD with previous PTCA stenting, hypertension, dyslipidemia, and carotid endarterectomy in 2014. He had the AAA known since 2016. At the last check, we evaluated an increase of the AAA to 5.3 centimeters with proximal bulging. As you can see in the CT, there is a lot of thrombus inside in the aorta, and on the right side you can see the bulging close to renal arteries and the AAA localized to the abdominal aorta. Here you can see the proximal bulging and the thrombus quite close to a superior mesenteric artery, so that there was no proximal neck for EVAR. We decided to treat him in open repair, so with ERAS protocol. We are going to evaluate our approach, our usual protocol, according to the ERAS guidelines. First of all our patients are evaluated preparatively by a team of surgeons and anesthesiologists, and they are informed of the program and learn how to use the VAS, visual analog scale. And they also receive information on respiratory exercises before and after surgery. All the patients are allowed to eat up to 6 hours before the operation and drink clear fluids up to 2 hours before the operation. We usually have a transperitoneal aortic approach with subcostal incision or xiphopubic mini laparotomy with 10-15 centimeters of the incision. We usually maintain the bowel inside in the abdominal cavity, and as in this case, we perform a suprarenal cross clamping and for the most an ortho-aortic dacron graft interposition. These are images of our patient with the incision and the abdomen, the bowel inside the abdomen. And you can see we use soft clamp for the aorta to maintain the clamp outside the surgical field. Usually we perform this intervention in 3 or 4 people. In all patients, we use a cell saver. We try to maintain the body temperature, to maintain a state of normal volemia without fluid overload. And sometimes our anesthesiologists check this volemia with transesophageal ultrasound. We don't put drains or nasogastric tubes at the end of the surgery, and all of the patients are awakened in the operating room. According to the guidelines, so we don't put the drainage in surgical site, we don't insert nasogastric drainage, we promote oral feeding and remove very quickly the urinary drainage. Usually in the day, the afternoon of the day of surgery, we remove the bladder catheter, or if the ICE test is positive in POD1. Every hour we check all the parameters of the patient, and in the afternoon of POD0 or in the morning of the POD1, we promote the patient to lift up from the bed. And once the patients are able to drink freely with no nausea, we remove intravenous fluid. So we are aggressive with the early mobilization strategy because it led us to discharge the patients after 2 or 3 days after the intervention. As I cited before, this is our paper of the suprarenal cross clamping, and as you can see, we didn't have any significant alteration of renal functions in the patients treated with suprarenal cross clamping at 6, 12, and 24 months follow-up. In conclusions, I can say that ERAS protocols have emerged as an effective approach to optimize perioperative care and improve outcomes. The guidelines emphasize the importance of the multidisciplinary team approach, patient education, preoperative optimization, intraoperative and postoperative care. Current evidence supports the implementation of ERAS protocol, highlighting the positive impact on patients' outcomes, recovery, and resource utilizations and cost savings. Thank you for your kind attention.
And thank you very much, Dr. Settembrini. Our final presenter for this evening is Dr. Hans de Boer, who was the co-chair of the guidelines writing group with me. He will be presenting Guidelines in Practice, Lessons Learned from Building an Aortic ERAS Program. Dr. de Boer is probably the best person in the world to give this talk, as he serves in the ERAS Society Executive Committee. He is a staff anesthesiologist and pain specialist in the Department of Anesthesiology and Pain Medicine, Procedural Sedation and Analgesia at the Martini Hospital in the Netherlands. And his work in that group has allowed him to develop multiple different complex ERAS programs, including one for open aortic surgery. His specific interests include neuromuscular management, perioperative management and patient safety, and also innovations in anesthesiology. He's also been integral in implementing opioid-free and opioid-sparing anesthesia techniques. Dr. DeBoer, thank you very much for joining us this evening. The screen is yours.
Good afternoon to everyone. My name is Hans de Boer. I'm an anesthesiologist from the Martini General Hospital in Groningen. And first of all, I would like to thank the Society for Vascular Surgery for participating in this webinar. I will talk about the guidelines in practice and the lessons learned from building an aortic ERAS program. These are my conflict of interest. And this is the agenda for today. I will talk about the value of innovation in healthcare, and we'll discuss the healthcare challenges and traditional approaches. And actually, what is the standard of care? And what means variation in care, and how to reduce it? And improving quality and draw some conclusions. So often ask the people, what is innovation in healthcare? And many give the answer, new drugs or devices. But innovations are not limited to new drugs or devices. It's about organization, it's about the patient, it's about the physician and the nurses. But it's also about information technology. And some of the most important healthcare innovations are in the way the delivery of care is organized. And actually, we have to realize this is how we work. We work in silos, although it's multidisciplinary. And that has limitations. I will come back on this very soon. We also have healthcare challenges, and in this major landmark publication in Lancet about global surgery 2030, we have to realize that 5% of the population is operated in the Western world. This means 320 million operations annually, of which 25% will face any complication. And they state that there is a huge variation in care. And when you want to change, it takes 15 years approximately to change practice globally. But also we have an aging population, a demand for better care, but also diminishing funding. So the traditional approach in healthcare, based on the perspective of the surgeon anesthesiologist, nursing, or the HIP. We are searching for new techniques, a search for new technology, with benefits for the patients and improve outcome. But based on the perspective of the hospital decision maker, they state that innovation is important, but it's often too expensive. Improved outcome is okay, but where is the financial benefit? Budgets are increasing year by year, and cost saving is the main goal. But how and where, that's the question. This is also applicable for the vascular surgery, which means we have a huge challenge to overcome our goals. So the traditional approach in healthcare means that there is a huge variation in healthcare. Variation in healthcare provision and outcome is huge between countries, within hospitals, and even between individual doctors. And the main reason for this is that a few evidence-based treatments are used and measured. And evidence-based standards, processes, should be defined to minimize unnecessary variation in care. So actually what you can say is that traditional approach in healthcare is extremely expensive. Let's take a closer look. What is standard of care? So the concept of the standard of care is often discussed among physicians, and yet the legal definition of this term is frequently not understood. Actually, there is no clear definition. So what can be considered as a standard of care? Treatment that is accepted by medical experts as a proper treatment for a certain type of disease, and that is widely used by healthcare professionals, which is also called best practice, or standard medical care, or standard therapy. However, the problem is that the persistence of a suboptimal standard of care long after evidence-driven approaches would dictate a change, which means that the standard of care lags behind best practices. And the problem is that standard of care is not synonymous with the best or evidence-based medicine, resulting in the persistence of ineffective and even harmful medical interventions, which is more often called evidence-based medicine. So ERAS can reduce variation of care. It is evidence-based perioperative care. It is multidisciplinary, multi-professional, and this is also approached like this. It's teamwork, and the continuous interactive audit and reporting of the data is important. So it's a data-driven change. We have to realize that also the teams have the readiness to make the change. But how to improve quality of care? This is an interesting paper of JAMA Surgery from 2022. 3 observations for improving efforts in surgical quality improvement. So the first observation was data are essential, but not sufficient for achieving high quality. The understanding that data are part of the solution, but not all of the solution must become better. Improvement efforts needs to be conducted well. Sounds logic. The resources, professional skills, and expertise required for improvement efforts need to be recognized, systematized, and supported. And the third observation was small-scale local surgical improvement efforts are common and need to be supported. However, more tools are needed to support the execution of these efforts. So this is also applicable all for the patient journey in open aortic surgery in the pre, intra, and post-operative period. It's multidisciplinary, multifactorial, and evidence-based medicine should be applied, which is summarized in the aortic guidelines. So this is how we should work. We should come out of our silos and go horizontally like ERAS is doing. So in conclusion, ERAS exists almost 30 years and is a generic term. The aortic guidelines are relatively new and give a good direction of evidence-based medicine in this surgical field. The incentives should be academically and scientifically approached, should be available globally, inclusive rather than exclusive. And actually, these guidelines can be implemented in every hospital for low costs. And implementation is not that complicated. So we see ERAS as a logic development of an improvement initiative in healthcare over time. So the perioperative care in open aortic vascular surgery, it is also like the statement on the website of the Society for Vascular Surgery, transforming vascular health through research, innovation, and comprehensive care. Thank you for your attention.
All right, thank you very much, Dr. DeBoer, and to all of our speakers today. To recap, we've had presentations from Drs. Spangler, Howell, Ayash, Settembrini, and DeBoer. Thank you also to all of our attendees for taking the time to be here. Of course, this is a recorded session, and so you can always refer back to this or send it to others in the future. In consideration of the time difference for our international presenters, some of them are not on the panel, but Dr. Howell, despite it being in the middle of the night in the UK, will be joining us. And also Dr. Joy Garg will be joining us in the panel. He is a California-based surgeon who was part of the writing group for the aortic guidelines. And he practices in the Department of Vascular Surgery at Kaiser Permanente in San Leandro, California. So we've got Drs. Howell and Garg and Spangler here in the panel to join me. And there's a few questions that have come through on the chat. Please continue to submit questions. There's a few straightforward questions, well, potentially straightforward questions about some of the recommendations, and then a kind of a more global question about institutional and structural barriers in implementing a successful program. So let's start with some of the easier ones. How long after elective aortic repair should patients be prescribed with antibiotics? Obviously, they do a single dose preoperative prophylaxis. If the case is prolonged or has massive blood loss, you may redose the antibiotics in surgery. And our guidelines do not recommend any further antibiotics. Does everybody in the panel agree with that? And is there extra use of antibiotics in your practices?
The guidelines allow for up to 24 hours of perioperative antibiotics based on the regimen from that. So our institutional practice, because of the implantation of the graft material, is to typically continue those several perioperative doses, but there's not evidence to support longer use. Most of the antibiotic data was largely from the 1990s and before, so there's not been new innovations in that regard.
Similarly, 3 post-operative doses in Leeds over 24 hours with exactly the same strictures about the evidence base.
We do the same. We do the same here. 24 hours of post-operative dosing. The only exception is if there's significant blood loss during the case, then we consider 1 extra dose during the intra-op phase.
Okay, excellent. Next question, fluids in the intraoperative and postoperative period. The anonymous poster here says, should we always be using Plasmolite?
So we don't use Plasmolite in Leeds. We don't have it. It's not a crystalloid that's routinely on the shelf for us. We would reach for Hartmann's as our sort of alternate, as our probably nearest equivalent. I would, on the whole, I think the evidence base now mitigates against colloids, that there is evidence, generally evidence of harm from colloids, and no clear evidence in favour. That certainly from the point of view of anesthesiologist, we would wish to avoid a high chloride load, and therefore we'd want to go for something more balanced. I'm not aware of evidence that clearly shows an advantage of either Hartmann solution or Plasmolite. I think there's a bit more of a tendency towards alkalosis with Plasmolite, but I think metabolically it does have some calorific value, but certainly not always Plasmolite, because for us it's never Plasmolite.
Emily, Joy, do you have anything to add?
I can't comment as much on the intraoperative course. I believe it's largely LR for us. In our aortic ERAS protocol that's about to be implemented, it's LR for the early perioperative resuscitation stop.
Yeah, our order set here has LR as the primary choice with NS as the backup.
All right, perfect. The next question was to get a little more nuanced about when to place drains in the surgical field. There's not strong evidence in support of a recommendation, but we did comment on this, that all drains should be avoided. But are there times, especially after an elective aortic repair, that you are leaving drains? And
I'll start. I guess we don't routinely put drains at all. The last patient we put in a drain was not a typical aortic case. It was an explant of a graft, and it was an aortoenteric fistula. So for the duodenojejunal anastomosis, we required a drain, but primarily aortic work, we don't recommend a drain, nor do we use one.
Our practice is similar.
yes, likewise.
I think the thrust for the evidence had been that these should be sterile operations for the most part. And so therefore, mostly what you would be at potential to drain would either be lymphatic collections or hematomas, which are probably not effectively done those ways. And that it was a sort of broader principle in ERAS is assuming that some of these tethers potentially limit the patient's normalization.
All right. The next topic is to expound upon the strategies for intraoperative and postoperative fluid administration. There was some discussion from Dr. Ayash about the balance between liberal and restrictive fluid resuscitation. And the poster here says that it would seem that this is a pivotal strategy to allow for early extubation, avoiding NG tubes, maintenance of renal gut and myocardial perfusion. And so how in real time are you evaluating your patients and deciding when to administer or withhold fluids?
So I guess I think this one's really difficult for vascular surgery patients. I mean, I think it's much more clear cut in GI surgery. In our practice in Leeds, we tend to use non-invasive cardiac output monitoring, pulse wave analysis, and use stroke volume variability as a guide to fluid administration and aim to keep that below about 10 to 12%. But it's a noisy signal, and my clinical experience, and I suspect probably that of much of the panel, is that aortic surgery patients do seem to have a high fluid requirement, and that walking that line between the use of vasopressors and fluids can be quite challenging. But to try and bring some objectivity to it, in our own practice, we use stroke volume variability as a guide.
That is something that, as Dr. Howell is mentioning, it's a bit of a give or take there. We also don't. I find myself sometimes struggling with this part also. That you end up finding that the patient may be slightly under-resuscitated, and I have to administer more fluids in the immediate post-operative phase. We are working on using various combinations of non-invasive cardiac monitoring, tracking lactate, but it is something that we are still trying to find the happy medium of.
Okay, tagging on to this delicate balance, one of our posters says that they find it difficult to limit IV fluids to 1.5 liters if epidural anal, and this is for daily postoperative fluid use postoperatively, which is based on Italian studies that patients who were limited to 1.5 liters postoperatively had better outcomes. But in the setting of epidural anesthesia and the presumed sympatholytic effects, they struggle to limit their fluid to just 1.5 liters. So do you use pressors? That potentially has the risk of increased AKI. What is the best approach? I'd like to tag on to this that if the patient comes out of the operating room with a relatively good fluid balance, and if you were judiciously following fluid balance, then the patient can probably eat and get up and move around more, which helps make this less tricky and less precarious of a balance. But if the patient is still NPO and still in bed and still with epidural, you may well need more fluid. And so how do you guys work through these problems?
So I guess I sympathise with the sentiments of the question personally, and with what Joy was saying earlier, that I think there are 2 or 3 studies out there that make the case for a more restrictive approach for fluids, and certainly from the sort of anaesthetic you're referring, Kate, to further down the line, but certainly for that first 24, 48 hours. I do find myself, much as Joyce said, often giving more fluids than I sometimes feel comfortable with. That I think the response to unclamping, what we used to in the old days to call third spacing, but effectively the loss of fluid into the tissues due to an inflammatory response, is a significant challenge in these patients. I think it's probably one. It's very, the glib needs more research, but I think for this particular population, I think it's an area where we probably do need to do more work. But I sympathise with the questioner, certainly in the immediate intraoperative and postoperative period. When I do try and restrict fluid, I find myself wishing I hadn't.
I think broadly this raises one of the challenges that ERAS and other specialties has sometimes faced, that sort of detecting when the patient is potentially not following along the guidelines of where this care is right for them. So in the intraoperative phase, the resuscitation parameters are going to be more individualized. The number of 1.5 liters tended to be more for in the early postoperative phase. And in some ways that can help with discussions that might be done for things like justification of clearing the tubules and giving diuretics and fluids concurrently, or things that sometimes ICU patterns persist in. That the drive towards an earlier return to diet hopefully allows the patient to auto-regulate a little bit more, but in the situation in which it seems that they're under-resuscitated or doing poorly due to complications or other issues going on, treating the underlying pathology is still important and resuscitating them appropriately, hopefully.
All right. Next question here is, do any of you have experience in TAP blocks in order to optimize post-op analgesia and early ambulation and avoid the epidurals? And so I would like to comment on this specifically, that for the guidelines, the only literature is around the use of epidurals in aortic surgery. And so we had to base the guidelines off of the existing data. But as many programs have developed larger, more robust regional analgesia programs, there has been a lot of use of other regional techniques aside from epidural, which seems to be institution-specific practice. But the reason why it's not discussed in the guidelines is because it is just that. It's just institutional experience and has not yet had any published literature for this patient population. But do any of you have experience with other types of regional blocks? And can you share that with us?
I'm reluctant to be the first to go every time, Kate, but yes, we do. So certainly one of my surgical colleagues likes to place rectus sheath catheters in the context of a transverse incision. And on the whole, with a PCAS, so long as we're careful about the patients we select, then that seems to work quite well. I think with a patient with significant COPD, for example, I think we would lean back towards an epidural. And certainly, anecdotally, we've had the experience, which is exactly I think the driver from the point of view of early mobilization and post-operative recovery, of patients very clearly saying, please don't take my epidural out yet, which leaves them a bit more tied to the bed. But certainly, with the right, with careful patient selection, not TAPS box, but surgically placed rectus sheath catheters in combination with a PCAS and with a transverse incision, we seem to work quite well. And certainly we would extubate at the end of surgery with that combination.
So it's funny you mentioned this. I actually did a tap block on my last patient. I'll let you know after he's discharged how it went. And again, as you mentioned, it is sometimes institutional, and that is sometimes the preference of our colorectal surgeons to do a tap block and lidocaine drip. So I'm trying that with
my experience is also only anecdotal. We aim for epidurals. The situation in which we've used the TAP blocks as a single shot were cases where their coagulation and antiplatelet parameters didn't allow for safe placement of them. So this can be a good window to allow discussions with your anesthetic team about what parameters are needed for cases to be able to proceed in the way that would allow the best analgesia.
Excuse me, Dr. McGinnigal. I want to
Yes.
announce that we will now launch the post-event survey for the attendees. Thank you.
Great, thank you. Give everybody a moment to take a peek at that and move it to the side of their screen and then In the meantime, we've got one more epidural-related question, which is in the setting where you're concerned for spinal cord ischemia, can you comment on the use of local anesthetics in the epidural and how you do a neurologic assessment for spinal cord ischemia? Joy, you want to go first this time to prevent Simon from speaking up until second or third spot?
It's been a tricky situation. In the patients that we had were worried about neurologic assessment, we actually elected not to put the epidural for that reason. And I remember my partner, he was doing it was a type 4, and we had neuromonitoring, so we had full neuromonitoring there as well. Whether that was the right decision or not, I don't know, but it did come up once for us. And my partner elected not to use the epidural in that case.
This might be a situation in which you would consider doing a different regional block.
Yeah.
And I think if for, certainly for abdominal surgery, it's about using lower concentrations of anesthetics so that you don't achieve a complete motor block, and doing regular assessments of motor function, I think, as far as we're concerned. And I think one of the better drivers for us of perhaps trying not to do epidurals is bearing confidence in whether those, I hate to say it, but bearing confidence in whether those motor assessments are always done properly. That they're certainly protocol to be done very regularly, but it doesn't always happen, truth be told. I guess probably linked to this is the question of what you do is if there's a bloody tap when you put the epidural in. And I know certainly I would put it to the surgical team that if that's happened, we shouldn't proceed.
Yeah, I think well said. Okay, so switching gears a little bit, and this is something that I think is a barrier to implementing ERAS across many different vascular departments. Can we really start early enteral feeding on postoperative day 1, even if there are no audible peristaltic sounds? Emily, you want to go first for this one?
Sure. So for our guidelines, the literature is largely extrapolated from some of the information we have from ERAS protocols that are in the upper GI tract, such as pancreatic and foregut surgery. That being said, that with limited intake, I think Dr. Setabrimi team had also shown that that was feasible and safe. I wouldn't necessarily go having a huge meal right afterwards, but within the first 24 hours, in the absence of active bowel sounds, it should still be okay to cautiously advance in patients that you think are higher respiratory risk or have other limitations in how their resuscitation has gone. They may be ones to steer a little bit more cautiously around.
Yeah, I concur. I think it's safe to consider starting at least sips of clears on postoperative day 1, at least see how they're doing with that. And if there's someone who you think is someone you can fast track and they're flying well, then you could advance to a clear liquid diet and see how they do and tolerate it.
Yeah, and personally, I have, the conversation with people that I would rather have a saltine than a chunk of Jello. And if I eat a single saltine, I'm not sure that the impact is going to be a whole lot different than a bowl of Jello. And so if you use common sense and kind of progress slowly, then I think that that's a reasonable thing to do for patients who, had an expected operative course and are coming out of the operating room relatively euvolemic. It's certainly reasonable. And just the way that we functionally make rounds and change orders, that if you wait for a patient to tell you that they are hungry and then you make rounds the next day and then you change the order, it's going to be a long delay between the clear liquid diet and when they're actually allowed to eat that saltine, much less anything else. And so setting the expectation with your patients and giving them some of the upfront responsibility to listen to their bodies and to communicate with their nurses and have the nursing staff communicate with the surgical team is important, but bending a little bit is I think also important. Otherwise, we just inadvertently delay care just based on the way that our processes are.
One other note on that is that our guidelines have largely been focused towards infrarenal aneurysm repairs. And so if you're ascending up into the thoracoabdominal segment more, then some of those considerations may be slightly different as well in terms of risk of ileus.
Yeah, correct. Okay, we've got a few minutes left before this session is over, and a general question. Have you found any institutional or structural barriers in implementing ERAS? And if so, how did you overcome it? And so I wonder if we could just kind of go around round robin style and talk about something that we overcame in working on ERAS programs in vascular surgery at each of our places.
I guess I can start. We took advantage of the fact that ERAS already existed for orthopedics and general surgery, and that really helped us with some of the multimodal analgesia, the early nutrition. What was interesting for me was, even though we had all the facility for early ambulation, convincing my partners that early ambulation was okay. That took a little bit of buy-in for them to see, yes, it's okay for your patients to mobilize. I know this is beyond the scope of this talk, but when we, for example, did ERAS lower extremity, I walked one of my patients 6 hours after the bypass, taking advantage of the PT that we have in the PACU for total joints. So getting my partners to believe in the fact that you don't have to keep these patients in bed for 48 hours to 72 hours, get them up and moving the next morning. I think that was the biggest hurdle we had, and I think that's made the biggest difference for us.
Emily?
Like Dr. Garg, we benefited from having some significant enthusiasm for ERAS principles in general and other surgical specialties before we began our programs. We began with a lower extremity bypass protocol first, and then bridged out towards amputation, and are now in the process of trying to implement an aortic one. And a not permanent, but delay barrier has been actually getting the EMR build to align for the protocols that we have for fluid management for our aortic ones. More broadly, that for aortic work, this is one situation in which ERAS is extending across more sites of care and more teams than may otherwise be in place. So for us, we have an ICU setting that had not been part of the majority of the rest of our ERAS protocols. And with that, we did some qualitative work to understand better what some of the providers as well as nurses for that unit might feel or know about ERAS to begin with. And they were very receptive in general to the concept of it, wanted to learn a little bit more about the evidence, and then really said that the education and implementation of it would make a big difference of how well they felt it would be adopted. So making sure to consider how familiar different groups might be with these things. And then lastly, that different settings of care have different resources. So while ERAS works very well for multimodal pain control at the university, at a different setting of care, some of those struggles are more significant where we don't have a block team or an anesthesiologist around to follow up epidural care on the weekends, those sorts of things. So think about the infrastructure of what your facility offers and what bridges you can build, and make sure to engage all the teams to help make sure you're moving towards a common goal, not stepping on someone's foot for care that might not align.
And Simon, ERAS principles have really been standard of care in the UK for a decade longer than they have here in the States. But what words of wisdom do you have about overcoming obstacles as they come up?
I'd like to pick something really. So they have. I think they took a real knock in COVID, and a lot of the specialist ERAS nurses who were diverted to other duties during COVID somehow didn't come back. Fluids, or trying to deal with starvation for fluids, which should be really simple, seems to remain a real challenge. So, fasting guidelines say no clear fluids for up to 2 hours before surgery. In practice, it's often longer than that. Dealing with that remains a work in progress. There's a drive, I would suspect it's the same with yourselves, to go towards subcutaneous end, that people can take clear fluids until they're actually until we actually send to them for theatre. And that's not become institutional protocol, but I think a number of us are doing it, and I'm hoping that will lead us to a solution. But I think a barrier remains a deeply ingrained institutional reluctance to move to allow people to drink fluids until close to the time of surgery, in case the list order changes, in case something happens. Overcoming that remains a work in progress, sadly.
I agree with that, and I think I'd like to reiterate one of the slides that was presented earlier was a commentary by Adam Beck, who works with Dr. Spangler at University of Alabama. And he says there's no I in ERAS. And we also had a very robust ERAS program at my university hospital with over 20 different surgical divisions that took a real hit during COVID. And that's because a lot of our team shifted and a lot of the routine work went out the door, and things that we took for granted were no longer so easy to get done. And so getting everybody aligned and thinking very carefully about the infrastructure that you have available to you at the time, whether it's in a time of shortage, like staff shortages related to COVID, or now in the United States, we have an IV fluid shortage related to hurricane damage to the IV fluid factory. Or just, shortage of your own bandwidth as a surgeon, and how much time you can spend with each of your patients. Thinking about that and thinking about how you can get people to align around the same goals to fill in some of those gaps to maintain some of the ERAS fundamentals has been key, but that's very hard. And the more that your hospital can get around making the right thing the easy thing to do, and setting up order sets and kind of automated processes, I think the easier it becomes for people who are new to the system to fall into the pathway. So then all of a sudden everybody is getting ERAS, and you are looking for the person who is not actually on pathway, who needs the extra attention, and you're diverting your attention to the people who need it. That's the goal, of course. And with that, we are at time. Thank you all very much for attending the webinar. Thank you to the presenters and to the panelists. It has been an absolute pleasure to spend the evening with you. Take care.